So first, I would like to welcome Dr. Seema Pandey, who is the director Seema Hospital and she's the president of Azamgarh Obstetrics Society and a national executive member ISA. Welcome, Dr. Seema, and may I request you to please take the proceedings forward.
Namaskar, good evening. My esteemed faculty and senior members of LOGs and all my viewers, on behalf of Bridging Bharat and TOG webinars, I welcome you all to this very interesting concept of webinars conducted by all the regional societies. Today's our topic is RH-Allo immunization. So while looking at the video which TOG was playing, I just remembered few lines about Lucknow and I would like to share with you all. बात आई मोहब्बत की तो लोग शब्द ढूंढने लगे बात आई मोहब्बत की तो लोग शब्द ढूंढने लगे हमने एक लफ्ज में शहर लखनऊ लिख दिया So that is the beauty of Lucknow. So welcome you all, and it is my proud privilege to introduce our first speaker, who is a senior most, very dedicated gynecologist and a teacher par excellence. The moment I put this post in my group of Azamgarh Society, and there are so many students of Madam, and they were so happy that Madam and all the senior faculty from there, they are going to teach us, and that nothing else can be said about Madam beyond that. She is President LOGS at present, HOD Ram Manohar Lohia Institute of Medical Sciences. Previously, she was a professor and she had so many accolades to her credit, including Best Teacher Award, many papers and scientific delegations. I welcome you with privilege and honor, ma'am. Please take up the stage and over to you, ma'am.
Thank you, Seema, for your kind words. I am thankful to you that TOG, because of the TOG, the Bharat Bridge program, you are coordinating this Bharat Bridge program and you have asked Lucknow OBGYN Society to organize this program on behalf of the TOG and the Bharat Bridge program. So I'm thankful that you have given the opportunity to LOGs to organize a very academic and very important topic is the RH negative allo immunization, which is a very important topic of today. So today we are going to deal with the RH ABO. Dr. Seema is a very eminent physician and IVF specialist. She's working in Azamgarh and Gorakhpur both. So she is the one who is very active in all ISR. You are very active. I know that. I keep on looking at your pictures of the ISR, and you are also active in the FOXY. So with this, I am not going to read your degrees and everything. But I know you are the one who is a wonderful person, and you have given the opportunity for me and my colleagues, Dr. Smriti and Dr. Shipra, to organize this program. So I'm thankful on the behalf of Lucknow OBGYN Society to you and the talks and the Bharat Bridge program. Thank you, Seema.
Ma'am, there are people waiting. It's such a confusing topic and interesting topic, and people like you can clear all those queries. I've got 1,000 questions. So over to you. Please start, ma'am.
Thank you. Where is the share screen? I should go?
Yes, ma'am. Down.
Yeah. Here. Yes. Where are my slides?
By the time Madam is looking at the slides, let me remind you all, my dear faculty, we are having more than 2,000 audience to look at, and there many more will join later.
The session, can you help me, please? Mr. Session, can you help me?
Yes, madam. I think if you go and double click on the RH negative PPT, I think it should open, madam.
Okay.
Yes.
So, it's visible to you all, I suppose?
Yes, madam. everyone can see.
So at the outset, I would request all my audience that I am contesting for the post of Vice President Norzone Foxy. So please do vote and support me. The election is going to be in the July, August, and I'm looking forward for your support, for your precious vote. Thank you. So I'm going to talk today of the overview of the RHD, LO immunization in pregnancy. It's a very important topic and very confusing also. Mr. Session, is my half the slides has been covered by this side panel. So how to remove this side panel, I suppose? Hello?
This is only visible to you, ma'am. The viewer can only see your share screen part. That is your PPT.
So if I go to without the full screen, I can see all my slides. So is it
Yes,
okay
ma'am.
if I don't go to the full screen?
You
No
have to,
problem,
ma'am.
madam. Please proceed.
Okay. So RH-D negative women who deliver a D positive baby or who are otherwise exposed to D positive red cells are at risk of developing anti-D antibodies. The D positive fetuses or neonate of these mothers are at risk of developing HDFN, the hemolytic disease of fetus and newborn, which can be associated with serious morbidity and mortality. So it is very unfortunate that despite availability and implementation of anti-D prophylaxis, HDFN continues to occur worldwide. So a small dose of anti-D given as an antenatal and postnatal prophylaxis can significantly reduce the frequency of D-LO immunization and associated fetal and neonatal complication. If HDFN occurs, because it is not always because of the D antigen, it could be because of D antigen, it could be because of other antigens. It is a treatable at the dedicated centers. Only thing, the person has to be under constant monitoring and touch and see that where the person has to go. So there's a little bit about the rhesus system, which is very confusing. I will try to solve it a bit, clarify it. The pregnant woman is RH positive and RH negative, which we do it as a basic investigation in our antenatal OPDs. One should know there are more than 50 variants of this antigen is present. The few are the capital D, capital C, capital E, and small e. There is no small d is present. So a woman who is D negative can form the antibodies against D as well as against the C, E, and E antigen if exposed to the fetal C, E, and E antigen, which is inherited from the father and is absent in the mother or the index mother or the woman. So anti-D prophylaxis will protect her from D antigen only when the anti-D D antigen, D antigen is present, but it will not protect against the C-LO immunization. So when we do, it is very important to do the zygosity, and 40% are homozygous and rest are heterozygous. The rhesus system, we have to say one more thing, because often everybody must have seen. There's a one lab has reported as a RH positive. The other report is saying RH-D negative. So why this occurs? Because there is a weak phenotype, D phenotype, or the D is present but it has not been expressed. So in some cases, the D testing, there is a weak or less than 2+ reaction is there. But when you add anti-human globulin, it makes a strong reaction. So this happens when there is a serologically weak phenotype is present in this mother. So there's a big clinical dilemma, especially when the woman is coming with one report is RH positive and the other report is RH negative. So how to solve this clinical dilemma? We know that there are more than 200 mutations are there. But for the D, important is 1, 2, and 3. So this 1, 2, 3, if it has been found, this genotyping has been tested further. If this has been found, the woman will be labeled as RH positive. So there will be no need of the anti-D in this woman. If this 1, 2, 3 is not found, it will be labeled as D negative and it will need a anti-D prophylaxis. So it is very important to see whether this confusion is whether she is a genotype D123 positive or D123 is absent. to know whether she will need an NTD or she will not need NTD. If she does not need an NTD, we give NTD. It's a cost which has been involved. If she needs NTD and we have not given, we know that we are going to face a lot of problems in the neonate and subsequent pregnancies. There's another thing which I would like to emphasize is, as I have already said, there's so many antigens are there. So if the fetus is having these antigens and is absent in the mother, the mother can be illuminized with these antigens. So it is important in this scenario, because there is a one woman who has been pregnant and delivered and she has been given an NTD. But if you see in the subsequent pregnancy that her titers are positive. So in this situation, you have to see whether it is NTC or NTD, because sometimes it can happen because of certain reasons that you have given the NTD, but still she is not been well protected. So it is important to see whether it is a NTC antibodies or NTD antibodies. So absence of NTD antibodies are there. Then there is an indication for NTD immunoglobulin prophylaxis. If NTD antibodies are present, the NTD is not going to help this woman. This NTD, I would again like to say that NTD immunoglobulin does not protect against C-allo immunization. We do not have anything against the C-allo immunization. So we have to do, if mother is C-allo immunized, we have to treat her as non-RHD cases of allo immunization, and we have to go through the different protocols, and we have to treat this person which is beyond this, which is not beyond this talk. So I'm not going to deal with this. So these indications for NTD prophylaxis are all non-allo immunized women for D antigen. NTD at 28 weeks should be given. This is a grade 1A evidence. There's some Canada and some other associations say that it should be given at 28 and 34 weeks. But the American Association of OBGYN says it should be given only at 28 weeks. Weak D antigen genotype 1, 2, 3 is not found. That means she is Rh negative, D negative, and mother should receive a NTD. Allo immunization with NTC or from non-RHD NTD, or from non-RHD, but NTD antibodies are absent. In this case also, you will need a NTD prophylaxis, and you have to know whether these antibodies, NTC or NTD. If D antibody is absent, you have to give NTD. Any procedure in D negative pregnant women is a grade 1B evidence. I am going to go through next slide. I am going to show you all the procedures with which a woman will need NTD prophylaxis. So if the woman has delivered a D positive fetus, the ideal dose is being given most of the time, which is sufficient, which can cover 15 to 30 ml of the feto-maternal hemorrhage, is 300 microgram within 72 hours. It is also a grade 1A evidence. Postpartum NTD gives partial protection. So if inadvertently it is not been given, it can be given up to 13 to 28 days if the mother has not received NTD in the immediate postpartum. It will give some protection, not the full protection. Post-sterilization for the protection of mother, NTD should be given or not. It is a controversial topic. Definitely, she is not going to conceive, but sometimes there is a failure of the sterilization may occur and she may conceive. Or in the later life, she may need a blood transfusion. And if she develops the antibody, then she will not be able to take any other blood group. So it is better to give her even she is going to be sterilized. Women undergoing intraoperative cell salvage dose is calculated based on the Kuhler-Burkitt test. So we have to, because this is one of the very important thing which is going on, and people are getting these machines in their OTs, because it is difficult to get the blood, and the blood which may be having certain other problems. So intraoperative cell salvage is one of the option which should be done to give the blood. So here you have to, if she is Rh negative, because this blood will be having a fetal cells. So one has to go to a KB test and give the NTD dose. So suppose it is 1.5, because 1.5, that means it is 85 ml. So 30 ml is going to be covered by the 300. So rest is going to be 50 ml. You have to give 1.8 or the 2 ampules more of NTD to this woman to give her the full protection. So this is a list This is a list of the procedures in which the fetal-maternal hemorrhage may occur, and the woman may need NTD. Is a delivery, induced abortion, spontaneous abortion, ectopic pregnancy, partial molar pregnancy, chorionic villus sampling, podocentesis, percutaneous fetal procedures like fetoscopy, amniocentesis, external cephalic version, abruptio placentae, antenatal hemorrhage, and maternal abdominal trauma like motor vehicle accident, fall, or the assault, and the MRP. So it is better in all these things are being associated with fetal-maternal hemorrhage. So one will need a NTD prophylaxis after each and every procedure. What is the pathogenesis? It is only at 38 weeks of the gestation, the expression of D on the fetal IBC comes. So maternal alloimmunization occurs as a result of exposure of D positive IBC to maternal immune system. So it occurs as early as 38 weeks. Maybe this pregnancy has not continued. It has been vanishing or it has been aborted before the woman knows. So because of this only, we get many of the women in their first pregnancy is being seen that they are alloimmunized. And when you do, it is a NTD alloimmunized because in the first pregnancy, this has happened, but she did not know and she had a complete abortion without her knowledge. Or there is a grandmother theory is also one of the things to explain this. So IgG antibodies, it is not the IgM, it is the minute, it is the IgG antibodies cross the placenta and opsonize the fetal RBC. What are the events can cause the maternal alloimmunization? One, I've already talked, the transplacental fetal-maternal bleeding during the pregnancy because of the several procedures. The list I've already shown you. The injection with needles contaminated with D positive blood. So remember, nowadays it is very good that we are not using the used needles, but in case where it is being used, this is one of the cause of the alloimmunization in the mother. Inadvertent transfusion of D positive blood or the D mismatched allogenic hematopoietic stem cell transplantation are the other events which cause the maternal alloimmunization. So this is the list which I have already shown you. So I am not going to do it again. Factors that affect the alloimmunization are it is not that effect is going to be the same in all. It will depend upon volume of the fetal blood in the mother circulation, frequency of the fetal-maternal bleeding, ABO incompatibility of the mother and fetus, the immunogenicity of the fetal RBC and immunogenic response of the mother. It has been seen the women who are having the low immune response, like in the AIDS, it has been seen the allo antibodies are not formed. So it is the immune response of the mother is very important to have the amount of the alloimmunization. Similarly, the severity of the fetal anemia depends on many factors of the maternal antibodies. So it is a prevalence of the many countries. It has been because it is a ethnicity and race based. So the population which is living near the Spain and the France, it has got the highest prevalence of 30 to 35%, but in India it is only 5%. So how to screen this woman who has been alloimmunized or she has not been alloimmunized? So indirect womb test, which is being used universally. There are two other tests which are in pipeline, the gel microcolumn assay, which is under consideration because this is a manually test tube based agglutination test, but this is not a mechanical test, but it is still not being used. It is under consideration because it is giving a high titers. The automated enzyme methods is not being constant. So diagnosis depends upon the diagnosis of the de-alloimmunization depends upon detection of the NTD antibodies in the maternal blood, and detection of the allo antibodies means the fetus is at risk. It is not that fetus has developed the HDFN or it is going to develop. It is only the risk, and the further monitoring will tell you whether the fetus has been developed HDFN or has not developed the HDFN. So false positive is also, there could be, the results could be false positive. The woman received NTD immunoglobulins in past few weeks, especially when you give at 28 weeks. When you see at the term, the titer may be less than or equal to 4 at term. So this is the one which says that it is because of the NTD given by the 28 weeks. But if the titer is higher, it suggests that there is a allo NTD, new allo NTD will be formed, and there will be IgM, not IgG. So IgM antibodies does not cross the placenta, so we don't have to worry about it. The management of this aluminization is somebody we are going to deal with in the cases, but there's a only outline is the determining the fetal D type is very important, which can be done by the amniocentesis or NIPT. We prefer NIPT because if we know the fetal group, we know that whether we have to give NTD or not and what is going to be the prognosis of this pregnancy. Monitoring for the fetal anemia if the fetus is D positive. And this has to be done by the invasive or non-invasive method. The invasive method is a chordocentesis, or non-invasive method is a PSV of middle cerebral artery. The zygosity of the paternal RHD, we have to do a PCR. The monitoring also depends upon the clinical scenario, whether it is a first pregnancy or a second pregnancy, whether it is affected pregnancy or it is a non-affected pregnancy. So you do a serial NTD titer. And non-invasive, as I've already said, the USG is a MCA PSV. It is being done 2 weekly. But if you see the antibody titer is rising, and reaching near the 1.5 mom, which is a critical value, weekly or earlier monitoring of the for the monitoring of fetal anemia can be done. It can be done weekly or earlier, depending upon, because you have to, if it is remote from the term, you will need a intrauterine transfusion. It has been seen that MCA PSV, if it is less than or equal to 1.5 mom for gestational age, is consistent with non-development of moderate to severe anemia. If it is more than 1.5, only then we think that it is a severe anemia is going to develop. But if it is less than 1.5 or equal to 1.5, we know that we are not dealing with a fetus which is having a severe anemia. As I said, invasive is chordocentesis. Most of the time, the chordocentesis is only being done when you need a intrauterine transfusions. So there's one meta-analysis has been done of the 12 studies, 2008 to 2018. All the 696 fetuses are being included into this study. And it has been seen when PSV is more than 1.5 mom, had a sensitivity and a specificity of 86% and 71% respectively for the prediction of moderate to severe anemia in non-transfused fetus. If the fetus has already been transfused, we know that this value will alter. So this is only one slide which has been showing how to measure the middle cerebral artery PSV. It has also been seen that there is a 1.5 mom, but if it is more than 1.8 times of the fetal biometry, MCA velocity, what is should be at that gestational age, if it is more than 1.8 times, it is also significant, and it shows that there is a fetal anemia is developing. So it is just that if the previous child is being affected, the monitoring should be done 18 weeks or lower, depending upon at which gestational age the previous pregnancy was affected. If the previous pregnancy is not affected, you can start this more than 22 weeks and that antibody titer is present. But if the antibody titers are high, it is 1 in 256. Earlier monitoring by the USG, MCA, PSV can be done. There is a critical titers have also been said. The titers of more than 4 by the KEL, because there are many antigen. So this KEL is a very important antigen, and they say because many antigens are present, few are sensitive and few are not sensitive. KEL is the highest studied factor, and if it is more than 4, is for the monitoring by the fetal MCA. It is an indication that the fetus should be seen by MCA PSV from 18 weeks onwards. In other antigens, if it is more than 16, is an indication for MCA PSV. So titer should be repeated every 3 to 4 weeks. In case of rising titer, it should be done 1 to 2 weeks. The critical titer in fetus at risk of developing severe anemia or the hydrops fetalis. Below critical titer, fetus may develop mild to moderate anemia. So the critical titer is 16 to 32 is being considered as a critical titer. In Europe or somewhere, it is only 15 is being considered. But so we also take, because our centers, those who are dedicated centers, they are having their own critical values. But those who are not having, they only go with this values. So neonatal is the HDFN. It is hematocrit normal because of the intrauterine transfusion. So now this baby when born may not need a top-up transfusion and it will need only at 1 month. It takes some time to begin reticulocytosis and disappear maternal antibodies, 5 to 15 weeks. Most but not all de-aluminization can be prevented by NTD to the woman exposed to the high risk of being exposed to D positive RBC. Once aluminization has occurred, NTD is not effective in preventing the HDFN. So if the woman is already aluminized, the NTD should not be given. So options in those women who are having severely affected fetus for in the recurrent pregnancies. So how to get a healthy baby, because prevention is very is not cost effective. So in case of women at risk for very early severe fetal anemia, the intrauterine insemination by the Rh negative donor is one option. Pregnancy by insemination with the sperm from a D negative donor is other answer. IVF, intrauterine transfusion, is one answer. Pregnancy by insemination with sperm from D negative donor is another option. IVF and PGD, to know that this blastocyst is D negative, only then it should be transfused. This embryo should be transfused, otherwise not. Or if nothing is possible, you can have the option of gestational carrier. So coming to the concluding remarks, the rhesus system consists of D, E, E, C, and C. And G antigen is there is a protein change on the membranes of the RBC. So if the D and C will be present, the G will be present. Include partial or weak D antigen, as I've already said. Because of that, the confusion of Rh positive and Rh negative comes. The maternal de-aluminization occurs due to the exposure to the D positive RBCs. The diagnosis of aluminization by detection of NTD antibody in maternal serum. At first, so it should be done at first prenatal visit. Then the woman comes and she is Rh negative. The D typing and the antibody screen should be done at first visit. So we know that she is not from the beginning is NTD positive. If negative, then repeat at 28 weeks and then so on as the things goes on. In presence of discrepant D gene, the patient should undergo the RHD genotyping for the weak D types 1, 2, 3 to know whether this is Rh positive or Rh negative. The monitoring for aluminization for antibody titer, MCA PSV for development of the fetal anemia, and ensure NTD prophylaxis in all cases can prevent the HDFN, and it is a very cost-effective treatment. So in case of aluminized women with BOH, option is to get healthy baby R, intrauterine transfusion, Rh negative donor, IVF and PGD, gestational carrier. Thank you very much. And again, I request you for friends for nominating me as a vice president for Foxy North Zone. And I request humble for your support and looking forward for your support and for your precious vote. Thank you so much. Dr. Seema, you have to.
Yeah. What an insightful presentation, ma'am. You have covered almost every doubts in your presentation. However, we have many questions and we'll come back in the end to clear those doubts which we had after listening to such a detailed description about Rh alloimmunization, ma'am. So now I would like you to introduce our next faculty, ma'am.
Yes. So the next faculty is my very dear persons is Dr. Shipra Kuwar, who is MD FICOG, FMS, MRCOG UK. She is a consultant Medanta Hospital, Lucknow, ex-professor and head of the ERA Lucknow Medical College. Special awards and achievements. She is a regional faculty certificate course in diabetes, awarded Best Researcher of the Year 2017 by the Indian Society of Hypertension, the second best speaker in Speed Geeking session at midterm update, and Best Paper Award in AICOG 2020 in Gynae Onco. We all have seen. So publication, more than 30 publication in national and international journals, and she is at the moment is the joint treasurer of the LOCS, Lucknow OBGYN Society. So Shipra, now up to you for the case discussion. She is going to discuss a very interesting case. Shipra, unmute yourself first. Shipra, now over to you. Can you hear me?
Yes, ma'am.
Yes, thank you. Now you are visible.
Okay, ma'am. Right. So I thank you so much, ma'am, for the kind introduction. and giving me this opportunity to be here. I have a small but a very practical case discussion. We tend to come across Rh negative pregnancies regularly. So I've just brought about the points which might be a little, sometimes we tend to get unnerved and just to revise what we need to do in an Rh negative non-isoimmunized pregnancy. So I'll just share my screen. Give me a minute. So can you see the slides?
Yes, we can.
Okay. So this is the first case. She's a 25-year-old lady. So she's a 25-year-old lady. She's second gravida, previous one abortion, came to the OPD with an amenorrhea of 2 months. Her first pregnancy was a spontaneous miscarriage at 2 months of gestation, and she has not visited any doctor in previous pregnancy. Antenatal investigations were done, and in which the blood group came out to be AB negative. So the first thing which comes to our mind is how to go about further. So we need to check if anti-D has been received in previous pregnancies. So we have already, this patient has never been to a doctor. So we know in this case, but, and routine antenatal investigations, of course, are advised. Here, for Rh negative case, we know that a husband blood group needs to be done first. So if the husband is Rh negative, we don't need to do anything further. But if it is positive, then we need to know the hetero and the homozygosity, which ma'am has already talked about in her lecture. But practically, actually, I have never done that, and most of us wouldn't be doing that. So if you have a husband which is a blood group which is positive, the next thing we need to do is an ICT, that is an indirect Coombs test. Now, knowing the cell-free fetal DNA and knowing the blood group, yes, ma'am also mentioned about the NIPT. That is a possibility, not maybe very easily available, but maybe in near future, because in UK they've started doing that. So her husband's blood group came out to be positive, A positive, and an indirect Coombs test was negative. And she, at 10 weeks of gestation, the patient comes to the labor room with bleeding per vagina. What should be the course of management? Again, ma'am has said, and she has told about how to manage a patient with bleeding. There are sensitizing events which occur. So all guidelines have a little different point of view whenever you read through them, the ACOG or the RCOG. But once going through the ICOG, which has published and a very brief article about Rh isoimmunization, it says that significant bleeding during threatened abortion. There is a little confusion. RCOG, it says if there is bleeding with pain, then only you need to give in first trimester of pregnancy, or else you don't need to give it in first trimester of pregnancy. But ICOG clearly states that our own FOGC Indian guidelines states that if you are in doubt, it's better to you give a lower dose, you give 100 microgram, but give anti-D if she has come to you with threatened abortion. So even it mentions spontaneous miscarriage, medical termination, you need to give it soon after misoprostol. Surgical termination, every guideline says you have to give it. Molar, again, there is a confusion if it's a partial mole or a complete mole, because molar pregnancy does not exhibit anti-D or Rh factor. So there is a confusion whether to give in partial or complete mole. So the consensus is in molar, you need to give it. There is no doubts, you have to give it. Chorion biopsy, you need to give. Embryo reduction, you need to give. So, and of course, last but not the least, which is not there in the slide, is the ectopic pregnancy, post-ectopic, you have to give. So what could be the sensitizing events in the second and the third trimester? That is an amniocentesis. She has an abruption or a previa with bleeding, or a blunt trauma, IUD, or she undergoes an external cephalic version. Again, you need to give. Now, what would be the dose? So the first trimester, it is 50 to 100 microgram. So 100 microgram is easily available. You can give. If there is significant amount of bleeding, you can go in for a 300 microgram. So, and in second and third trimester, it's always 300 microgram. The administration should be in the deltoid muscle, because it is said in the gluteal, it may go into the subcutaneous space, or into and it may be very slowly absorbed. So that's not an ideal way of administering anti-D. Deltoid is the place. And now time, it is 72 hours. We all know it is 72 hours. Within 72 hours, it should be administered. But if in case the patient is unable to come, or you are unable to give it, 10 days is within 10 days is also sufficient. So you need to follow it up and give it within 10 days. Now, she was advised anti-D. She did receive her anti-D. At 20 weeks, she again had one episode of antepartum hemorrhage, for which she was admitted, and a blood transfusion was also given. Should another dose of anti-D be given? I'm sure everybody will agree to me, and the answer should be yes. And repeat anti-D has to be given at 6 weeks interval. There's a confusion. ACOG says 3. Actually, Americans have a lot of money. Every 3 months, 3 weeks, they might give an anti-D. We can follow the RCOG. RCOG says it's 6 weeks clearly. And an ICT should be done at 28 weeks. And routine antenatal anti-D prophylaxis needs to be given in case her ICT is negative. That is the protocol. So her indirect Coombs test is negative at 28 weeks. She receives a single dose of antenatal anti-D. That is 300 micrograms at 32 weeks. She's now 40 weeks at gestation. How should you manage further? Now it becomes, this is simple. There is no confusion. You do not repeat, you do not need to give any anti-D prior to at 40 weeks. It's only if she's received her anti-D, antenatal anti-D before 24 weeks, then you may think of it, but it's better to deliver and then give it postpartum rather than giving it antepartum. She definitely needs an induction at 40 weeks. You do not continue the pregnancy beyond 40 weeks. There should be an early cord clamping. You need to avoid methogen. You need to avoid doing a manual removal. And anti-D postnatally 300 microgram within 72 hours. And if it is missed, that you can give it even up to 28 days. So if 3 days is missed, it should be ideally 3 days, but if it is missed, you still have time up to 28 days. So just a little bit about what are the tests which we are performing to see for isoimmunization. We have the indirect Coombs test. So what is basically an indirect? We talked about doing ICT. So ICT is basically seeing the antibodies in the maternal serum. So we take the maternal serum and we incubate it with Rh positive cells. So these anti-D bodies, they tend to stick onto these cells, and then we add the anti-human immunoglobulin, that's the Coombs antibodies, and that will cause an agglutination. So this will tell whether the antibodies are present in the maternal serum. So a direct Coombs test is done in the fetus, in the baby once it's born. And then you need to, the blood sample from the patient is taken, and what you need to do is just add the Coombs reagent. And if the antigen and antibody, they are already there because the antibodies have crossed over from the placenta into the fetus. And so there would be clumping once the Coombs reagent has been added. So a DCT should be done post-delivery from the fetal fetal blood. So you need to take the fetal sample to see for the hemoglobin. You need to see the blood group of the baby and also do the DCT. So the cord sample has to be sent for these evaluations. So there's another test which is rosetting test. People want to know what's exactly about these. This is basically again a quantitative test. If you just want to see if there are anti-D present. So rosetting test can be done. Rh positive fetal cells from rosettes form rosettes with D positive indicator cells. Positive rosette test is an indicator of doing a Klehoff-Betke test to see for, so there you can quantitate how much the fetal-maternal hemorrhage has occurred. So how do you calculate for the dose of anti-D? That is dependent on the that you can determine from the Klehoff-Betke test, and it is an acid dilution technique in which the fetal erythrocytes contain hemoglobin F, which is more resistant to acid dilution than hemoglobin A. After exposure to acid, only hemoglobin F remains, such that after staining, the fetal erythrocyte appear red and adult cells appear as ghost cells. Fetal cells are counted and expressed as a percentage of adult cells. The hemorrhaged fetal blood volume is calculated by the formula. Fetal blood volume is equal to maternal blood volume into maternal hematocrit into percentage of fetal cells in the Klehoff-Betke test divided by the newborn hematocrit. So we generally give 300 microgram, that is 1500 IU is given for 15 ml of fetal blood cells to be neutralized. And if there is a more, and if you do a fetal-maternal, if you do a Klehoff-Betke test, you can know whether if the fetal-maternal hemorrhage is more than 15 ml and it has not been neutralized. In that case, a further dosing with anti-D can be done. So, so a little word of advice for why is it important that we need to immunize all is because the rate of isoimmunization is almost 16% if you're not giving anti-D, 2% by the time she's delivering, 7% by 6 months post-delivery, and 7% are sensibilized. That is, they might still be not showing any antibodies or ICT will still be negative, but only positive in the next pregnancy when she becomes pregnant the next time. So thank you so much. I'll end with this, and the next, I think Dr. Seema can summarize the case.
No, I've had many questions, a wonderful presentation. So few questions from my viewers and from my side. Shipra, let me tell you that you had done an excellent job. You didn't leave much for me to ask. Can you just stop sharing your screen, please?
Yeah, sure.
Yeah. So one question I wanted to know, Shipra, since this patient was G2 para 0A1, do you think Rh isoimmunization or Rh negativity brings abortions or is a cause of infertility, subfertility?
No. There's a Rh isoimmunization would not be a cause for
that previous abortion was due to this Rh negative, being it a Rh negative pregnancy?
Rh negative pregnancy would not cause repeated abortions. So it is not a cause for recurrent abortions. So what we need to understand is it can cause pregnancy wastage or IUD in second or the third
later gestations, but not for the first time.
Not for the first time. Usually, yes.
This mother is not sensitized to Rh positive blood, chances are unlikely that she's going to get first miscarriage because of Rh isoimmunization. Second thing I wanted to ask is the recommendation is the moment you find a lady to be Rh negative and husband is Rh positive, you have to get her anti-D titer done as a baseline at the first visit. So,
Yes.
yes. And Dr. Shipra, you were talking something about cell-free DNA. Could you just elaborate it, please? I could not understand very clearly when you were talking about it while just talking about your
Yes.
patient.
So cell-free fetal DNA.
Mhm. How it is that we should take a question answers at the end, Seema?
Yes, no,
Or
ma'am, we will take according this related to this case. I will take
okay.
just few questions and then we'll keep the question answer session from
Okay,
public in the
okay,
end.
no problem. Because I said that first it should complete because I also have few questions.
Okay, ma'am. You
I thought
yes, ma'am. This is just those questions which I just wanted public to know clearly because
okay,
she had told everything in that case presentation,
okay,
and
okay,
any one of you can answer. And rest of the questions we are going to take. We'll just take 5 minutes in these questions. So
okay.
we just wanted to know about cell-free DNA, Shipra.
Would basically cell-free fetal DNA would tell the blood group of the baby. So I'm not sure whether how much we are doing it in India, but
Yes.
definitely it has started in UK. They have defined for a separate pathway for women who get cell-free fetal DNA and know the baby's blood group.
What is
Because
this? Yeah.
if the husband is an RH positive and there is he can be heterozygous or homozygous. In case he's a homozygous, it's almost sure that the baby is going to be positive. If he's a heterozygous, then there's a 50% chance that the baby might be RH negative. And in that case, there's these women who have an RH negative fetus itself almost would receive an anti-D which is not required. So if you have a cell-free fetal DNA and you know the baby's blood group, so these women, we can avoid giving anti-Ds to these women. So it's
So,
an unnecessary intervention for
so
these.
what is the sensitivity and specificity for this particular condition for
Uh,
cell-free
um,
DNA?
uh, it's somewhere around 80% as far as I remember. And ma'am can, if anybody has the different,
Anybody can answer, yeah.
yeah.
So it is good for if the fetus is male fetus. But if the fetus is female, you will need a different because it is will be it is difficult to say it is from the mother or it is from the fetus. So you will need further exon testing for it. So I
Yes.
believe that if the fetus is male, the cell-free DNA is a good test to get the fetal karyotype done.
Excellent, ma'am. So, do
Fetal,
you want to
fetal group, fetal blood group, not the karyotype, fetal blood group is done. Yes.
so, ma'am, do you want to state that cell-free DNA is only of use when the sex of the fetus is male, and it could be misleading in cases where the unborn
Yes.
child is female? That
Yes.
is the gem which we wanted to know, ma'am. And second thing, Dr. Shipra and Madam and Dr. Smriti, anyone, I wanted to know, like, your patient had multiple episodes of bleed, and have you given NTD to after each episode, or did you follow some protocol for that?
So there's a conflict here. If you go through the ACOG guidelines, they would say that it says 3 weeks. If there's a gap of 3 weeks, you need to repeat the anti-D. However, if you read the British guidelines, they say it's 6 weeks. Our own Foxy has not mentioned anything on this, how repeatedly given. But I think a 6 weeks duration is fine, especially because it's a costly medication.
Cost effectiveness is being maintained. So, do you mean to say if she's bleeding multiple times, even during that duration of 3 to 6 weeks, she doesn't need to take the repeat dose? And do you get this NTD titer done again before giving the second injection, or you just give it on the basis of bleeding episode?
No, you need to get an ICT done. Definitely, you need to get an ICT done before giving the anti-D. That
And what do you follow in that NTD? What comes then you give, and what is the criteria when you don't?
see, we do expect if it is negative, then you have to give it. But if it is positive, then you know you don't require to give an anti-D at that time.
And then you have to repeat the title for weekly and look at accordingly you have to give. Okay. And every medical abortion, ectopic pregnancy, all these sensitizing events, even madam has done it very excellently. She has told about all these episodes. And you are also stating that all those females who has first trimester abortions, medical, are they need, do they need this NTD or only after instrumentation? There was a confusion regarding with painful bleeding, you have to give. If it is painless abortion, you don't have to give. Just can you clarify it for me?
Yes, ma'am would like to take that question.
Yes. It is, if there's any kind of the threatened abortion, any kind of the fetal-maternal hemorrhage, it should be given because it is cost effective. Somebody has said that it is expensive. I will not say it is expensive because if the fetus has developed SDFN, it is very, very expensive and too much anxiety on the mother. And these days it has become it is so expensive now also, and it is available in the public hospitals. Best part is it is available in the public hospital also, free of cost. So there is, because they used to be constrained when it was not available in the public hospitals. Now it is coming, so we are giving it regularly and frequently without any problem. And we are seeing that it is less and less SDFN we are now getting into it. So it is very cost effective if you give it.
Okay, ma'am. Thank you so much. So here I would just like to conclude what our expert has said, that RH isoimmunization or being RH negative doesn't bring first abortion, or it is not a cause of primary fertility. Later on, when a woman gets isoimmunized or she did not receive NTD, she may have consequences for that. And whenever this, yes, ma'am.
Yeah, I just want to emphasize that more than 8 ampules should not be given whenever you calculate by the KB test. So it is, like I said, if it is going to be 85 ml, so it is going to be like 3 ampules. But at any time, you should not give more than 8 ampules. If you need
at once.
Yeah, if you need to give more, you give it today and you give after 24 hours or 48 hours. The next dose which has been required and you have been calculated by when there is a massive hemorrhages are there. When there's a massive hemorrhages there.
Any specific reason behind that, ma'am?
I suppose because maybe the saturation of the, I do not know the exact cause, but what the hypothesis comes to my mind is because your system has got certain limits to protect.
It is like
it is more than this, probably it will not be effective in protecting because it is already the highest concentration which a woman need, the body needs, is already been given. So your things will be saturated, your cell surfaces.
Very important information, ma'am. So any woman who is found to be RH negative, her husband's blood group has to be confirmed and her RH antibody titer has to be sent as a baseline on first visit and has to be repeated at 28 weeks, and giving one NTD if that is negative and husband is positive is really cost effective. It is not going to add to the cost which she might face later in her life. And NTD again has to be repeated within 72 hours of delivery if baby is RH positive. I think I have cleared. And don't just wait. If somebody comes to you even after 72 hours, you can give NTD up to 6 weeks postpartum. Whenever patient is in your contact, please do give this NTD. It will save something. Same with antenatal hemorrhage. If this lady has come to you even 10 days after the hemorrhage, if you found it to be RH negative pregnancy, don't hesitate to give one shot of NTD after sending her titers. Am I right? So with this, we'll take up the next case. Madam, I would request you to introduce our next faculty, please.
It's my pleasure to introduce the next faculty. Dr. Smriti Agrawal. I don't have any slide, but I can say she is a additional professor at the King George Medical University, and she is a brilliant faculty. Her achievements are member of core group of revised EMOC curriculum of MOHFW, member of expert group of formulating guidelines in medical disorder and obstetrics and tuberculosis for Ministry of Health, GOI 2015. Expert in the panel to develop protocol for the pregnancy care childbirth for District Hospital, College for Ministry of Health, Family Welfare and Government of India 2012. Joint Organizing Secretary of AICOG 2020. You all have visited and you have come and you have seen the grandeur of the AICOG which Lucknow has done. We are all proud of it. The special interest in fetal medicine, reproductive medicine, and clinical attachment at King College of London in fetal medicine 2014. She's been trained in the advanced ART course at the Milan, Bangalore. And publications, she has got more than 40 publications. She's an excellent teacher, par excellence, and she's a good human being. So now, Smriti, over to you. You are going to present a case which is isoimmunized, I suppose.
Thank you so much, ma'am, for the kind introduction. How much time do I have so I can hurry it up and we can finish in time?
You just go about the case. Viewers are waiting eagerly to listen to you and you have to clear all the doubts.
Yeah,
whatever
we can extend for 15-20 minutes, no problem.
Thank you, Yashodhara ma'am, and thank you, Seema ma'am, for giving me this opportunity. I'm so honored to be associated with both of you. And I think most of the topic on RH isoimmunization and anti-D has been covered very widely. So I will not like to repeat, but there are just a few things which I would like to highlight in this case. I have taken a case of a woman who is a third gravida with previous 2 abortions, and she has never taken anti-D because she never knew her blood group as well. Now she comes to the OPD with 8 weeks pregnancy, and she is found to have a blood group of O negative. As ma'am and Dr. Shipra have just told that it is important that we get a husband's blood group done, which turns out to be positive. And then as per the protocol, we begin and we start doing her indirect Coombs test at the first prenatal visit only. Now indirect Coombs test now is positive. So now the problem comes as to how to manage this lady who has an ICT positive. Now the points which we need to discuss in monitoring her this pregnancy are, what are the chances of fetal affection? Is there any role of fetal Doppler? When to give anti-D if there is any role at all? When to deliver, how to deliver? And if she wants to plan her subsequent pregnancy, what are the things we need to tell her? So this patient, when she comes with an ICT report which is positive, we need to counsel the patient as well as her husband. And now just having a positive report is not enough. We also want to know what is the titer. The antibody titers, when quantified, are reported in dilutions like 1:2 or 1:4 and so forth. Her titer comes out to be 1:4. Now, when an antibody titer comes out as positive, we need to repeat her titers at 4 weekly intervals because we need to understand that a fetus in situ, inside in utero, which is positive and the mother is negative, the process is ongoing. So we need to keep repeating the ICT titer at 4 weekly interval. If we realize that the titers are rising rapidly, we can also repeat them at 2 weekly interval. Ma'am had also touched this point. We must remember that the titers should be done in the same lab. Otherwise, it can create a lot of confusion in her management. Whenever her antibody titer reaches a critical level. Now, a critical titer can be variable, as ma'am had also just told. But usually in institutes and laboratories, we usually take it as 1:16. By critical, we mean it is not that things are going to be very bad, definitely. It just means that the chances of fetal affection are high and we need to act. Now, Dr. Shipra just highlighted about cell-free DNA, which I think is very important because we can't be blindly managing the patient. If the male partner is heterozygous, then there are 50% chances only that the baby is going to be D positive. So the baby is D negative, we will unnecessarily be hassling our patient, making her take the injections, making her undergo the fetal monitoring, Dopplers. So it is always good if you have a facility to get her RH, to get the RH status of the baby. It can be done by a non-invasive technique like NIPT or amniocentesis. Now, amniocentesis, because it's an invasive procedure, it is usually reserved where the titers are high, or if we think that the double marker report is also positive and we need to rule out other aneuploidies as well. Now, this lady who had a titer of 1:4 in her early pregnancy, is followed at 4-weekly interval. And when we reach at 28 weeks, now her antibody titer is 1:64, which is clearly above the critical titers. So now, since she's 28 weeks, usually we had just heard Dr. Shipra say that we need to give anti-D to these women. Should we give anti-D to this lady when she already has a titer of 1:64? Well, the answer is there is no role of anti-D now. We should not think that maybe if we need to give some, if we give some protective antibodies, we can prevent the worsening. This is not going to happen, and anti-D is not going to help her at all. So we should not give any anti-D further. Once the titer reaches the critical titers, we need to begin with the fetal surveillance. Because remember, this RH incompatibility or isoimmunization doesn't really affect the mother much, but the fetus inside may get affected in large amounts, and we need to monitor the fetus very well. Initially, when we were residents, we used to be doing the amniocentesis and looking at the bilirubin levels and the optical densities. But now, thankfully, we have a non-invasive technique, which is doing a fetal Doppler. Now, fetal Doppler is done for middle cerebral artery. The middle cerebral artery is chosen because it is seen that when there is an affection of the fetus, which leads to fetal hemolysis, it leads to fetal anemia. And because of that, there is increased blood flow in the cerebral arteries. As we can see in the picture here, we can identify the circle of Willis, and the middle cerebral artery is chosen and the gate is applied. So this is the kind of a picture we get. And we must remember that this is the systolic peak. So we have to measure the peak systolic velocity. Now, peak systolic velocity usually comes in centimeters per second. And here we need multiples of median to understand if the fetus is severely affected. So this is easily available in a conversion calculator at www.perinatology.com, which is free. And you just need to, I have a slide which shows, you just need to enter the gestational age, and you need to enter the peak systolic velocity, and it will tell you what the multiples of median are. So now the multiples of median, if the PSV is more than 1.5 multiples of median, we have to remember that it indicates that the fetus is having moderate to severe anemia, and we need to be very careful with this baby. Now, these measurements have to be done at regular intervals, 1 to 2 weekly. It all depends upon how exactly the titers are. So this lady is again followed as we have been following her. Now she's reached 34 weeks, and we have been doing her fetal Doppler every 1 to 2 weeks. All this while, the titers were less than 1.5 multiples of median, but now at 34 weeks, it comes out to be more than 1.5. So now we need to act as to how to deliver and when to deliver. And also we need to understand that sometimes peak systolic velocity, it may not be 100% sensitive. So we also need to look when we are doing the Doppler on the other ultrasonographic features of fetal affection. So now if we try to understand this slide, if the peak systolic velocity, it is less than 1.5 multiples of median, it clearly indicates that there is no moderate or severe anemia. That means even if the baby has anemia, it is only mild. We need to continue doing the weekly Doppler and see if the disease is progressing, and plan her delivery at 37 weeks of gestation. Obviously, inform the neonatologist in advance, because the baby may need good neonatal care and may also require phototherapy or exchange transfusions later on. But if the multiples of median is more than 1.5, this is the time when we need to worry about the baby. The baby may be having moderate to severe anemia. Now, if the gestation is less than 35, we have time to do something for the baby, and we can go ahead and do chordocentesis and intrauterine transfusion if required. I'll tell you in the next slide what are the indications for doing that. However, if the pregnancy has crossed 34 to 35 weeks, there's no point in doing in utero interventions, and it is a good idea to give corticosteroids for fetal lung maturity and deliver them. Now, intrauterine transfusions, whenever we are doing chordocentesis, we have to be careful and aware that we can't be pricking the baby again and again. So we need to have all the facilities ready for intrauterine transfusion. When we do chordocentesis, we take out a small fetal sample, and immediately we get the hematocrit level and the hemoglobin level of that fetal sample. If the hemoglobin is less than 2 standard deviations, below the gestation age, or the hematocrit to be in a simpler way is less than 30%, we can go ahead and give the intrauterine transfusion. For the transfusion, we need to arrange the O negative blood, and the hematocrit should be at least 50 to 60% because we cannot be overloading the baby and we need to reduce the plasma volume. The blood should be less than 5 days old. The blood should be CNV seronegative and the blood should be irradiated. The amount is calculated as per the hemoglobin deficit. Now, when we have crossed 34 weeks, then there is no further point in continuing the pregnancy further because, as I said, when the fetus is in utero, the disease progression is on. So now we need to deliver. So how to deliver is not a very difficult question because delivery can be as per the obstetric indications. However, if we think that the fetus is hydropic or anemic or the baby shows any signs of distress, then of course cesarean is a better option. As we can see here, these are the other ultrasonographic markers of fetal affection. We can look for ascites and we can also look for pleural effusion, scalp edemas, or hydropic umbilical cords. These give us an idea if the fetus is having anemia. So this lady was taken up a cesarean section after we gave corticosteroids for fetal lung maturity, and she delivered a healthy female baby whose blood group. So we need to remember one more thing before I complete that. Even if we have done an NIPT or if we have done a photosynthesis and ascertained the baby blood group, it is very necessary that we send the cord blood and we send it for various parameters, which also includes the blood group of the baby. Blood group as well as the direct Coombs test, so we know how the baby is affected. Now, once the delivery has happened, a lot of people, they think that we should still go ahead and give anti-D because maybe it will prevent the further progressions and complications in our subsequent pregnancies. But my friends, there is completely no role of postnatal anti-D because the mother is already immunized. Mother already has enough antibodies against the D antigen in her body. Now the question comes that if the woman is now worried and she wants to know what are my chances of having another baby. So there are certain things which we need to tell her that if she has had an isoimmunization in this pregnancy, there are good chances that she may have severe fetal anemia even in her subsequent pregnancies, provided the fetus is Rh positive. In subsequent pregnancies, the antibody titers are not going to help us much because she's delivered in a fetus which has a hemolytic disease. So repeated titers are not necessary, but a baseline titer is always good because it is written in the literature that if the titers are too high, even in the baseline, this woman will need immunomodulation and will need an expert physician to handle her. In these women, we should do the MCA peak systolic velocity being much earlier from 16 to 18 weeks. And of course, the rest of the management is similar, that we need to intervene only if the PSV is more than 1.5 multiples of median. So to conclude, I would like to say that we need to repeat the antibody titers till they reach the critical level. And we need to act only when the titers are more than the critical titers. And then we need to do the MCA PSV. And if MCA PSV is more than 1.5 multiples of median, we need to intervene depending upon the gestation. If it is less than 34, we can do photosynthesis and transfusions. If it is more than 34 weeks, then give corticosteroids and deliver. Dr. Seema, there are certain FAQs which we thought that we would like to take up because in case, if there are any doubts, we can clear them first.
Dr. Seema, you are muted.
Thanks, Dr. Smriti, for just deliberating an excellent presentation. And it has made things so simple and easily understood, even for those who did not know much about isoimmunization. And same was the case with Dr. Shipra, where she had dealt with non-isoimmunized cases. So, Smriti, if you just stop slide sharing, I have few questions of my own, which we'll take first, and then we are having a lot of questions from each of you through our viewers. So this lady who is isoimmunized and she has had one baby which was developed anemia and everything. As you have told in the last part of your presentation, next time when she's going to come to us, and supposedly, unfortunately, she had lost that baby in the previous pregnancy, and she wants to know whether the next pregnancy is going to be all right. Is there any way she can be like, we can confirm this thing to her, we can just reassure her that next pregnancy we are going to take better care and that baby is going to be safe? Is there anything which we can do about this? How to explain about it, Dr. Smriti, Madam Shipra?
Dr. Seema, this is a very pertinent question, and I would just like to simplify it by saying that if a woman has had RH isoimmunization and delivered a fetus who was isoimmunized, there are very high chances that she is going to have in her next pregnancy also, and in fact, the affection is going to be more severe. So what is important is we need to tell her, we need to also give her the options that she can have an intrauterine insemination with a B negative donor, sperm donor, or if she wants to undergo IVF, we can look into the RH of the embryos and then plant only the negative ones, or she can also, we should give her an option of a surrogate.
Yes.
But if she insists that she needs to go with the natural process, we need to tell her that we will, of course, be doing her baseline ICT titers, and then we will also offer her cell-free fetal DNA, so we note the antibody, the RH status of the fetus, because if the father, the partner, male partner is heterozygous, then we need not, we can still tell her that the 50%.
I'll just interrupt it here. You people are talking about heterozygosity again and again. Is there any way of testing this homozygosity and heterozygosity? If yes, then when should we do it? How should we go about it?
Yeah, so actually we get influenced by the Western literature, to be very frank. But yes, zygosity can be done by PCR levels, but as we understand that it is not very freely available, we can only tell the mother that because we are not doing it, and if the father is heterozygous, it is a 50% chance only. So she need not be so disheartened about it. And then we can
doing it. We are not doing it in father or mother before. Father, in fact, beforehand, before pregnancy, we are not testing it.
Yes, before pregnancy also, if we can do it, if the patient comes to us for preconceptional counseling, then yes, of course, we can do it in the preconceptional period. That way she will have a clearer picture.
That's what I wanted to know, how to go about it and how to do it.
Okay. And so only a baseline titer, and after that we need not do the antibody titers later on, because this is not going to give us any information. We only need to start doing her peak systolic velocity of middle cerebral artery as early as 16 to 18 weeks. If everything is going fine, we can repeat them at 2-weekly interval and intervene only if the values are more than 1.5 multiples of median.
So it has been added so that if you are having a previous pregnancy, at what gestational age it is being affected is also going to guide us that next pregnancy is going to be affected, but we should also keep in mind that it should be earlier. So we always expect a difficult next pregnancy in case of the previous isoimmunized baby. So this is what I would like to say that.
As usual, an excellent point, ma'am.
Yes.
Anything else do you want to add?
Yes. Zygosity of the father, at one time it was difficult, but I don't think so. Now in India it is going to be difficult, because in India we are having a lot of genetic labs, a lot of investigations. Everything is available, what is available in the West, except few things. Still we are not doing it because it is not under a protocol. If it is under a protocol, it will come to us. But definitely we are growing. The India is growing. So many fetal medicine people are in the field, and so many genetic centers are coming up. So many labs are coming up. So it is not difficult to get a father fetal zygosity done. And people pocket is also increasing. The insurance is increasing. The things are increasing. So we should be positive, and we should go this thing that if it is the so, and she wants her own pregnancy, she doesn't want donor semen or the surrogate or the IVF PGD, she can get it done, because there's a 50% chances that she may have this thing. And we all have seen that many times the woman comes with so much bad obstetric history, and we have so many investigations. At least the ultrasound is in our hand, which is a very important tool to know the middle cerebral artery peak systolic velocity. But still we used to see that a woman used to get a healthy child. So it is because the father must have been a heterozygous. So, but now we can diagnose and we can reduce the anxiety, because now you have to reduce the anxiety of the couple also, whether what is going to be the prognosis of the fetus.
Yes. So, as per my understanding, counseling is very important. We have to keep every available option in front of the couple, and it's up to them. They decide with whatever type they want to go. And our work is just to give them positive support. And as Madam said, that there are still 50% chances of getting good and normal pregnancy. So why to become hopeless? If she doesn't want to choose anything else, she has to hope, but she has to be in best of the hands where every facility is available. So my next question is, Dr. Smriti, how earliest you will start following these isoimmunized fetuses with Doppler studies and other stigmas associated with it when you are doing the ultrasound, and what is the sensitivity and specificity of this particular thing, Doppler MCA especially?
This is the first alloimmunized pregnancy. That means that this is the first time her antibody titer has come as positive. So in that case, she can follow with 4 weekly titers till the critical titer is reached, which is usually 1:16. If it reaches critical titer, then we start following up the patient with MCA PSV, right? Okay. And the sensitivity of MCA PSV in the meta-analysis is around 80%. If MCA PSV is more than 1.5 multiples of median, the sensitivity is around 80% to pick up moderate to severe anemia in the fetus, which is quite high. And if suppose she has already had an isoimmunized pregnancy earlier, so in that case, there is no point in repeating her antibody titers again and again. And we can straight away start doing her MCA PSV. Here we can start from 18 to 20 weeks onwards, because this child may have fetal affection much earlier.
Yes. So do you mean to say whatever gestation was the previous pregnancy she had started developing, we should start much earlier than that in next pregnancy? And that is a very good thing which you have been telling, and this 1.5 MOM. And one more thing I was confused about, that was chordocentesis and amniocentesis. When to do? Are you doing it for diagnostic purpose or only when therapeutic interventions are needed as intrauterine blood transfusion?
So, most of the times we should try and do invasive procedures as minimum as possible. So only when we think that MCA PSV is more than 1.5 multiples of median, and we need to probably transfuse the baby, so only then we should opt for chordocentesis. And as I said, we should do chordocentesis with full preparation of intrauterine transfusion, because we cannot be pricking the baby again and again. So when we do chordocentesis, we take out the sample and immediately within a minute we know the report, and then we do the intrauterine transfusion if required. If we think that the fetal hemoglobin is not too bad and hematocrit is not very low, then we can defer the intrauterine transfusion.
Excellent. And in this era of advanced, yes, ma'am?
At this point, I just want to emphasize that it is very easy to say middle cerebral artery PSV, but it should be done only on the skilled hands, because in the beginning it may need an angle correction to get the right report. And one other thing, there is a median of MOM is one thing, but for every gestational age, there is a value for the middle cerebral artery MSV. So if it is 1.8 times fold is more, that means this fetus is affected. So we have to see both. You can have MOMs, or you can just go to the gestational age. At that gestational age, what is a value should be of the middle cerebral artery peak systolic velocity. If it is more than 1.8 fold, then it means that fetus is affected. So it is also one should know.
Excellent, madam. So, in this era of excellent machines and these Volutions and all these machines which are doing excellent Doppler studies, do you think there is no more role of amniocentesis or any invasive kind of test just for diagnostic purpose? As Smriti said, that
Yes.
we should not pick again and again and
Most of the
make
time,
suffering. Yes.
most of the time, it has been done by the non-invasive test. When we are doing a chordosynthesis, we are doing for the therapeutic purpose.
Exactly.
So we are doing at the same time the investigation, the hematocrit and the blood group, and at the same time we are transfusing also. So it is being done with the preparation that you are at the same time you are doing the therapeutic also. It has not been done for the diagnostic purpose most of the time.
Okay, ma'am. So there is no role of diagnostic amniocentesis in this era. So
Yes.
that is our conclusion, and we can go with all the ultrasound findings that those are reliable, and we can rely on that. And accordingly, we can set our strategy. And this Doppler study should start either when the critical reaches to a titer reaches to a critical level, or from the history of the previous pregnancy, a few weeks before that. That is the message we want to give for RH isoimmunized patients. Now, coming to the questions, madam, it was an excellent presentation from your side, and it was too eye opener for me. And there was some confusions. I'm coming one by one as questions are coming. Madam, you have just mentioned about anti-C antibody. So people, they want to know what is this when you were talking about NTD.
C antibody.
Yes, sir.
Yes, because as I said, there are more than 50 antigens are present in the blood. So the few are capital D, capital C, small c, capital E, and small e. So if it is being present in the fetus and it is not been present in the mother, then the mother can be immunized by these for these antigens. So D antigen we can monitor, but other antibodies we only have to ask a special in the blood bank to know about whether the C antibodies are present or the D antibodies are present, because normally when we see, we take it that it's a D antibodies. But if we have a history that woman has been given an anti-D in the previous pregnancy and still she's showing the titer of anti-D positivity, so we get a doubt. So we have to know whether this is a anti-C or anti-D antibodies. If it is a anti-C antibodies, we know that it is, you have to give anti-D again to this woman. Normally, if we see the titer, it is high. We think that it is de-immunized. Allo immunization is already there. So we do not give the anti-D. But we have got a doubt that it is a C antibody, it is not a D antibody titer, it is a C antibody titer. So here, because D is absent, D antibodies are absent, you have to give the RH anti-D prophylaxis to this woman. And by giving anti-D prophylaxis, the C is not going to be managed, because we do not have any prophylaxis against the C immunization. We have to treat as the HDFN, that we have to see that when the fetus is developing the anemia and how to do, and you have to do ultrasound for middle cerebral artery PSV and see that accordingly you have to deal with this.
Okay, ma'am.
So, yeah. You cannot give a prophylaxis, but you can manage HDFN, that non-RHD isoimmunized fetuses.
So my next question is to Dr. Shipra. Whether anti-D is required during antenatal period or not. Dr. Vijaya Bhandari wants to know, and what is the effect of Rh negative blood group on fetus, Dr. Sushma Gupta? I think you can take those two questions. We have already covered, but you can just summarize for her. Unmute.
Sorry. So if a lady is Rh negative and she carries a Rh positive baby, so since there is an antigen present in the baby, and there is some amount of fetal-maternal hemorrhage which is occurring during pregnancy or during delivery, so some amount of bleed occurs from the placenta into the maternal circulation. This will lead to antibodies in the mother, and the first reaction is IgG antibodies, IgM antibodies, which will not travel across the placenta. But however, later on, the second reaction would be an IgG, which are smaller antibodies, and they can cross the placenta and actually they would destroy the RBCs. Rather, they coat the RBCs, and these RBCs then are destroyed by the fetal circulation. So the fetus would develop fetal anemia. So the question that how does an Rh positive baby gets affected is what happens in an Rh negative pregnancy is that the fetus would become anemic. Second, may develop hemolytic disease, that is severe anemia, later on leading to hydropic baby. That is, as we see in an adult, if we see what happens in a severe anemia. The severe anemia, there is generalized anasarca, there's fluid collection everywhere, and the same thing would happen here in fetal hydrops. There will be fluid collection in the fetus, and a hydropic baby, and later on there will be cardiac dysfunction, and we might lose the fetus. And this would happen at an earlier gestation with the next pregnancy she has. So the baby would be lost at an earlier gestation in further pregnancies. So this is why we need to first of all know the blood group of the mother, and in case she is Rh negative, we need to monitor these pregnancies and see that she does not become isoimmunized whatsoever. There was a second question. First, I think
you have already answered what is the effect of Rh negativity on the fetus. You have already clearly told it. Thank you, Dr. Shipra. My next question has already been answered by you guys. It is also by Dr. Sushma Gupta. What is the correct time to give anti-D? Antenatally? So it is at 28 weeks. I just wanted to know from Dr. Smriti, is there any particular idea behind giving this anti-D doses at 28 weeks, or is it just a random choice?
No, it is definitely not a random choice. It is supported by scientific evidence. The reason is that feto-maternal bleed happens most often in the third trimester. And we need to cover the delivery period as well.
Exactly, that's what was coming to my mind.
So when we say that the patient is going to deliver by 40 weeks, and we know that the protection lasts for around 12 weeks, so we know that if we give at 28 weeks, we will be able to cover the third trimester as well as cover her peripartum period, intrapartum period. So that is the reason we give at 28 weeks.
Okay, thank you, Dr. Smriti. So, Dr. Yashodhara, Dr. Sana Ansari is asking, we have already answered this question, should anti-D be given in cases of threatened abortion? You have already very clearly and beautifully told about it. Yes, it should be given. And the doses should be according to the trimester, isn't it?
Yes, but it is in our situation, it is not 100 microgram is not available. It is only 300 microgram is coming.
150 and 300. Yes. So we are giving 150 actually.
150, yes.
Yes, ma'am. The next question is very interesting. Do we have tests to D antigen genotype 1, 2, 3 available in India, and what is the cost? Dr. Naima Afreen. Who is going to answer it?
I will let you know. I can share my phone number and the WhatsApp number, and I'll let you know. At the moment, I do not have any idea about it. But I don't think so, because of availability of SAFE DNA, you know the fetal blood group. So here, I think so that you may or may not need it, because you are directly knowing the fetal blood group. If you know the fetal blood group that is positive, and this is a mother blood group which is positive or it could be negative, by doing the genotyping. So I'm sure that genotyping must be available. It may not be available to every person, because it is a demand. When the demand is generated, the your
supply will
test will be available. Your test will be available. because the company is not going to make only for one person,
Yes, ma'am.
2%. Company has to see their own benefit also. I have seen many times the good products have come and gone off just because they have not been accepted by the medical fraternity. And they were very good. They're very good products. But because the company said, I just said, why did you remove it? They said because it was not productive to the company. It is not only you who is going to use it. It is because everything is having different aspects.
Yes, ma'am.
So share my phone number 9838 226666, and I will give you this answer. Send me a WhatsApp.
Question is, since fetal sex determination is banned in India, so cell-free DNA sex determination, how legal is it? Is it allowed? Can we do it? Is it included in NIPT, which we are doing at present?
It is banned sex determination, but for the birth defects, your clinic has to be registered for it. Because your clinic, if it has been registered for it, for the malformations, for the hereditary disease, you can do it. Because at many times you have to do those tests for knowing fetal sex. Because many times
and all,
but you have to go through the proper channel to declare it.
Okay. So after ICT will come positive. If it's positive, should we repeat at 28 weeks? I think Dr. Smriti has clarified it. We have to just take one baseline title. Can you repeat it again, Dr. Smriti?
The rising title.
Question is, if it's positive, should we repeat at 28 weeks or not?
If it comes positive, we have to repeat it 4 weekly intervals.
Yes, you have to repeat it 4 weekly.
4 weekly. Okay.
To see whether it is rising or it is static, because you have to act according to the titers, rise in the titer.
So next question is, after 28 days, is there any benefit of giving NDD? So Dr. Ranjana,
not scientifically proved. Not scientifically proved.Maybe. Yes. So it is evidence says grade 1B evidence that it should be given up to only 28 days. 28 days postpartum. If it is not been given immediately, it can be given from 13 to 28 days. Not beyond that. Evidence is not there. Maybe is going to affect, but evidence is not there.
Okay. Next question is, if Rh negative pregnant patient has received NTD at first episode of antepartum hemorrhage, second episode of APH occurring 3 weeks after receiving NTD, them also second dose of, and so she wants to know, Dr. Prachi, whether second dose is required. So we have covered it. Dr. Shipra has told very clearly there are two groups of people. Canadian people believe it should be repeated every 3 weeks, while RCOG says it should be repeated 6 weeks, isn't it?
Yeah.
And do you want to add anything else into that, or we move on because we have so many questions?
Okay.
Very quick answer if you want to add something. Unmute.
Anything has to be added into it.
Unmute. Yeah.
Okay. Now, am I audible?
Yes.
Yeah. So, what we need to understand is that I would go by the 6 weeks, because we 3 or 6 weeks. Cost effectiveness is, of course, one of the things. You cannot keep repeating a 2400 injection every 3 weekly. So I would like to, because there is no clear guideline by FOXI as of now, but yes, 6 weeks you need to repeat. That's for definite. But
so we come out with our own.
It's a very severe bleeding. You've done some instrumentation, then you may think of, yes, repeating the dose.
Okay. So my next question is, what is the significance of doing the ICT of the husband? Dr. Nani Tandon is asking.
Never. Husband.
No.
We
don't need to do. Only when the husband start carrying the baby in utero, then only we will do ICT of the husbands.
Dr. Nani, you got
that group has to be done. ICT of the mother has to be done.
Yes.
So we can, once the fathers start bearing the babies in utero, then we'll start doing.
Yes, of course. We have to do it then.
We were talking about homo and heterozygosity of the husband, never about ICT. Yes. So if indirect Coombs test is positive, then what is the management?
if indirect Coombs test is positive of the patient.
Yes.
Yeah, so then we need to repeat the titers at 4 weekly intervals till the critical titer is reached. I think what Dr. Prachi has asked is that if RH negative pregnant patient having ICT negative at a first trimester visit and she doesn't have any episode and maneuver which causes fetal-maternal hemorrhage, then also ICT should be repeated at 4 weekly interval.
28 weeks.
The answer is 28 weeks only. If she's RH negative, then we
Only
repeat
28
weeks. It's only if she's positive, we need to repeat at 4 weekly interval.
Yes, to see the rising titer and how to manage, how to go further, because this monitoring will only give you a clue how to manage this pregnancy.
So almost there are so many questions regarding this ICT positive and maneuvers episodes of
Dr.
bleeding.
Seema, one thing I want to take up this question. If ICT is positive at 28 weeks, but below critical level, then anti-T should be given or not? The answer is no.
Yeah, just coming to that.
Yeah, if the ICT is positive, then we need not give any anti-T to her anymore ever.
Yes.
Unless it becomes negative, you don't have to repeat it. You just have to keep testing if you want to, isn't it?
Yes. Yes.
Every 4 weekly. In a case of AKH bleeds off and on throughout the pregnancy, how many times she requires NTD? If she is bleeding throughout the pregnancy.
Every 3 weeks she will have to do it, and we'll also have to repeat her antibody titers. If anytime they are positive, then we can stop giving, because that means she's protected.
Yes.
What about MTP pills negative patients? Is it mandatory to give half dose?
Yes, if the husband partner is RH positive.
Okay. What are the chances of sensitization if NTD is not given? Dr. Sanjeev Shah.
The chances of sensitization if NTD is not given, the chances are still not very high, I would say, because it is not necessary that every pregnancy the sensitization events would happen, but still the chances are high, maybe around 30 to 40%, but the fetal affection is high. So if the mother is sensitized, then it is quite possible that all her fetus are going to be affected subsequently. So this data is actually not very relevant, because I think that for a woman who is sensitized, for her, all the 100% of the fetuses are sensitized subsequently.
No, so I have mentioned in my talk that if it is being positive, that doesn't mean, or it is even the middle cerebral artery PSV is raised, it doesn't mean that all the fetuses are going to be affected. They are at risk of getting affected. Yes, they are at risk. They are at risk. Few will develop and few will not develop. So it will depend. Further surveillance monitoring of the pregnancy will tell you that how many is going to develop. So it may or it may not.
Okay.
But they are at risk. So you have to take, because they are at risk, you have to observe, monitor this pregnancy very closely, what is happening to this pregnancy. And at appropriate time, it should be terminated. If it is 34 weeks plus, it should be terminated, because there's no point to keep the fetus in utero, but it has to be in the tertiary care where the NICU facilities and the transfusion facilities are available.
Yes, madam. So before I come to next question, there is a message for Dr. Yashodhara Pradeep from Dr. Vibha Sharma. Very nice session. Amazing, Dr. Yashodhara ma'am. And then again, 2 messages for Dr. Shipra and Smriti. Feels good to hear from Dr. Shipra and Dr. Smriti ma'am after so long, as you taught me in my MBBS day by Dr. Zainab Hussain. So next question. It feels good when your students appreciate whatever you are doing. That feels amazing. So you must be very
only earns that.
Yes, that is funny. Yes, ma'am. So next question is, can NTD at 28 weeks cause alloimmunization?
This is protecting against alloimmunization.
I already covered in my talk. If NTD is being given and you test after 3 to 4 weeks, you may find that there is an antibody titer is there, but it will be less than 4 or equal to 4. So, and at term it will be, and this is not going to affect the fetus. So we don't, and we have to see that it is the IgM antibodies, not the IgG antibodies. So it is not going to cross the placenta. It is not going to opsonize the fetal RBCs. Yes, so if it is given at 28 weeks, you will get a titer. You may get a titer, but it will remain less than 4 or equal to 4. And it will be IgM antibodies, not the IgG antibodies.
Ma'am, I have a question here. Suppose she has been given, I think there's a question there also, if she's received anti-D at around say 20 weeks, and we do an ICT at around 28 weeks, and we find it in low values, that is 1:4, and do we give her anti-D or we don't?
See, you have to find it out whether it is a IgM or IgG.
No, Dr. Shipra, what did you say? At what gestation she has 1:4?
She received an anti-D at 20 weeks because she had an antepartum hemorrhage. She had some bleeding. Now we did a ICT at 28 weeks, and we found it in low critical levels, levels, that is 1:4 level.
We don't need to give. Because the antibodies are already there in her body, which are protecting the fetus. Yes.
Okay.
But after the delivery, if the fetus is Irish positive,
yes,
you have to.
If we will do the direct Coombs test of the fetus of the neonate after delivery.
Yes.
If it is positive, then we are not going to give any anti-D to the mother. But if it is negative, then we can give.
Yes, that is what I wanted to say.
Okay. So
there is a question here. It asks how much anti-D can we give? Dr. Shipra has given almost injections. So, so is there any clarity on that, and how much anti-D? As ma'am has already said, in one dose 8, I think. But here, because she was bleeding, and if it's a significant bleed, you need to give, you need to protect. So there's no question that you should not give her anti-D. 4 doses is because I have written 2 doses at 1 at 28 and 1 at 32. You can give a single dose at 28 weeks of 300 micrograms.
That is only 1 dose at 28 weeks.
I want to add.
I just want to add before we finish, because it was a question of early cord clamping. But now the evidence says that it should be a delayed cord clamping, because whatever the blood is there goes to the fetus. It is going to protect her by the oxygen, improving the oxygen carrying capacity, and it will not alter any phototherapy or any other status. So there was a time when we said that it is an early cord clamping is needed, but now we say that it is a delayed cord clamping, because it is going to give the blood to the fetus, which is going to increase the oxygen carrying capacity and going to protect the fetus. So this is what I wanted to add when it has come.
Before Smriti, you wanted to add something, and then after that we are going to have last question, and we have
Dr. Seema, I just wanted to answer Dr. Manpreet Kaur, where she has asked for how much can we give. There is nothing like how much can we give. We should not be giving too much anti-D together, because anti-D, so otherwise if we are giving that to protect the fetus at intervals, then it doesn't really, there is nothing like cumulative dose maximum which can be given.
Whatever it takes to prevent that isoimmunization, we have to take, but not to be given more than 8 injections
together.
Yes.
Together. Yes.
There's another question by Dr. Shweta Rajput. If the patient is not going to plan for next pregnancy, then is there any role of postpartum anti-D prophylaxis? I've covered in my topic and in my talk. Yes, it should be given, because she might change her mind after some time, or if she will not be given, she will develop an antibody, and later on if she needs a blood, then she cannot be, because all these women, as a life saving procedure, if negative blood is not available, they can at least one time can be transfused. So here she cannot be transfused, even that she will lose that chance, and she might change her mind after some time. So my advice, my counseling will be she should be given. If she does not accept, I cannot help it.
Yes. So Dr. Indu wanted to tell that roughly the affection in next pregnancy is around 10 weeks earlier than previous affection.
Yes.
This is right.
Yes, she is absolutely right.
With this, we have done with the question. What a delightful, excellent academic feast it was. I had got myself cleared so many confusions about RH isoimmunization and things, and I hope all our viewers, they got benefited by this excellent deliberation by Lucknow Obs and Gynae Society. I'm really thankful to all of you, Madam Professor Dr. Yashodhara Pradeep, Dr. Smriti, and Dr. Shipra. It was wonderful, wonderful, wonderful. One request before we go, that please, I'm wishing all the best to Dr. Yashodhara Pradeep, who is contesting for VP North Zone, though it is not official thing from my side, but yes, she is. I'm wishing her all the best, and I'm expecting same from all of you. So,
Best of luck, ma'am.
So my request to all the audience, please, 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 please do vote and support me when it comes in the end of the July or August. And I'll try to help you. Seema, I'm so thankful to you that you have given the LOGS a chance to organize this meeting and the TOG.
So Lox is my next door neighbor, madam. Thank you, Lox, for this association. And thank you, Bharat Serum and TOG Webinar Science Integra, for providing us this platform. For last few days, I have an academic group of few youngsters, and they were asking me to discuss RH alloimmunization and related to infertility and self-fertility and recurrent miscarriages. And I hope all those who wanted to discuss it, all their doubts must have been cleared. Thank you so much for giving the valuable time. We had a very, very good time here. Thank you so much.
Thankful to all the members who is watching this. I'm really thankful to those members.
Those viewers, they are our strength, and that was 2,000 plus, and all of them, I don't think that they were disappointed. They had a wonderful deliberation by three extremely talented academicians sitting among us.
Thank you from my side and my faculty side both.